Physiology is a set of balances held in place constantly, without being noticed, until it isn't. The Phantom Hyperactivity. The presentation to the primary care clinic occurred in late autumn. The weather had turned brisk, yet the patient arrived wearing only a thin, short-sleeved cotton shirt, describing a pervasive and unrelenting sensation of being overheated. The symptoms had developed gradually over the preceding 4 to 5 months. The most measurable change was a steady, unintentional weight loss of approximately 15 pounds. This reduction in mass had occurred despite a documented and marked increase in daily caloric intake. Alongside the weight loss, the patient detailed a persistent internal restlessness. It was described as a feeling of constant physiological exertion, as though the body were continuously running a race, even while completely at rest. Sleep architecture had deteriorated, fragmenting into short, unsatisfying intervals interrupted by a rapid heartbeat that fluttered noticeably against the chest wall. Furthermore, a fine, continuous tremor had developed in the hands, becoming particularly evident during simple motor tasks, such as holding a glass of water or attempting to write a signature. The initial clinical evaluation confirmed these subjective experiences with objective measurements. The vital signs immediately reflected a hypermetabolic state. The resting heart rate was elevated to 112 beats per minute. The rhythm was regular, but the pulse felt bounding to the touch. Blood pressure readings demonstrated a widened pulse pressure, an expected physiological response to the increased cardiac output. Physical examination further delineated the systemic acceleration. When the patient extended their arms forward with fingers splayed, the fine, high-frequency tremor was clearly observable. The skin across the arms and hands was notably warm, with a distinct moisture on the palms. Neurological checks revealed brisk, deep tendon reflexes, particularly at the patellar and Achilles tendons. To confirm the suspected etiology of these metabolic changes, a comprehensive endocrine panel was drawn. The laboratory results provided an unambiguous picture. The serum concentration of thyroid-stimulating hormone produced by the pituitary gland to regulate the thyroid was profoundly suppressed to undetectable levels. Conversely, the circulating levels of free thyroxine and triiodothyronine, the active hormones that govern cellular metabolism, were markedly elevated well above the standard reference range. This biochemical profile definitively established a state of thyrotoxicosis. Given the high statistical probability, the initial clinical diagnosis was Graves' disease. This is an autoimmune disorder wherein the body produces thyrotropin receptor antibodies. These specialized immunoglobulins mimic the action of thyroid-stimulating hormone, binding directly to receptors on the thyroid follicular cells and compelling the gland into a state of continuous, unregulated hormone synthesis. Graves' disease accounts for the overwhelming majority of hyperthyroid cases in outpatient settings. The patient's clinical picture encompassing the tachycardia, the paradoxical weight loss, the diminished heat tolerance, and the neurological excitability aligned seamlessly with established descriptions of the disease. It was a thoroughly logical conclusion, grounded in both epidemiological prevalence and classical symptom manifestation. Yet one specific aspect of the physical examination did not perfectly conform to this established framework. In the setting of Graves' disease, the unrelenting stimulation from circulating antibodies typically causes the thyroid tissue to hypertrophy. This diffuse growth generally results in a smoothly enlarged, easily palpable gland known as a goiter. The vascularization of the overactive tissue also increases so significantly that a clinician can sometimes hear a rushing vascular murmur through a stethoscope placed gently against the skin of the neck. However, when the examining physician performed a careful, deliberate palpation of the anterior neck, instructing the patient to swallow to allow the thyroid tissue to glide beneath the fingertips, the contour of the lower neck remained completely flat. The gland was not enlarged, and the tissue felt unusually soft and diminished, barely perceptible to the examiner's touch. This lack of glandular hypertrophy presented a distinct clinical incongruity. To fully appreciate why a hyperactive metabolic state would be accompanied by diminished glandular tissue, it is necessary to examine the foundational mechanisms of the hypothalamic pituitary thyroid axis. The regulation of systemic energy expenditure is governed by a highly sensitive, tightly orchestrated neuroendocrine feedback loop, a system that prioritizes precise homeostasis. The cycle of metabolic regulation originates deep within the architecture of the brain, specifically within the paraventricular nucleus of the hypothalamus. Here, specialized neurosecretory cells synthesize thyrotropin-releasing hormone. This small peptide is secreted into a dedicated vascular network, connecting the hypothalamus directly to the anterior pituitary gland, which rests just below it in the sella turcica. Upon reaching the anterior pituitary, the releasing hormone binds to specific receptors on thyrotroph cells. This triggers the synthesis and secretion of thyroid-stimulating hormone, a larger glycoprotein. This stimulating hormone then enters the systemic circulation, traveling downstream until it reaches its primary target, the thyroid gland located in the anterior neck. The thyroid gland is composed of thousands of spherical structures known as follicles. Each follicle consists of a single outer layer of epithelial cells surrounding a central, fluid-filled lumen. This lumen contains a viscous substance called colloid, primarily composed of a large glycoprotein known as thyroglobulin. The synthesis of thyroid hormone takes place at the precise interface between the epithelial cells and this central pool of colloid, a process entirely dependent on the continuous supply of iodine. Under normal physiological conditions, the thyroid gland actively extracts trace amounts of circulating iodide from the blood. This is achieved through the sodium iodide symporter, a transport protein located on the cellular membrane. This symporter utilizes a sodium concentration gradient to pull iodide into the cell, an energy-intensive process allowing the thyroid to concentrate iodine to levels many times higher than those found in the surrounding serum. Once inside, the iodide is transported into the colloid lumen. Simultaneously, the enzyme thyroid peroxidase facilitates the oxidation of the iodide and its attachment to specific tyrosine residues on the thyroglobulin molecules. The same peroxidase enzyme then catalyzes the coupling of these iodinated molecules to form thyroxine, commonly referred to as T4, and triiodothyronine, or T3. These newly formed hormones remain bound to the protein backbone, safely stored within the colloid until required. When the thyroid receives a signal from the pituitary via thyroid-stimulating hormone, the follicular cells engulf droplets of the colloid. Intracellular enzymes cleave the protein backbone, liberating the free T4 and T3 molecules, which then diffuse into the dense network of capillaries surrounding each follicle. In the bloodstream, the majority of the secreted hormone is T4, acting as a stable, long-lasting prohormone transported by specialized carrier proteins. As T4 reaches target tissues, local enzymes remove a single iodine atom, converting it into the much more potent and active T3. Once inside target cells, T3 binds to nuclear receptors to alter the expression of numerous genes. The physiological effects are systemic and profound. Thyroid hormone increases the basal metabolic rate by stimulating cellular oxygen consumption and energy expenditure. It upregulates the synthesis of beta-adrenergic receptors, making tissues much more sensitive to circulating catecholamines. This accounts for the rapid heart rate, the fine motor tremors, and the general state of neurological excitability seen in hyperthyroid states. Furthermore, the increased metabolic activity generates excess thermal energy, explaining the profound heat intolerance. To prevent this metabolic acceleration from progressing unchecked, the biological system relies on a strict negative feedback loop. As circulating levels of free T4 and T3 rise, they travel back to the brain to interact with the hypothalamus and the anterior pituitary gland. The presence of these hormones directly inhibits the further release of both the releasing hormone and the stimulating hormone. By shutting down the signal at the source, the native thyroid gland is instructed to slow its extraction of iodine and halt its production, allowing circulating hormone levels to fall back into equilibrium. Importantly, thyroid-stimulating hormone serves not only as a trigger for synthesis, but also as a vital trophic factor. It promotes the survival, vascularization, and cellular proliferation of the follicular cells. In classical Graves' disease, rogue antibodies mimic this stimulating hormone, relentlessly binding to the receptors on the thyroid gland. This unchecked stimulation forces the gland to synthesize massive quantities of hormone, while simultaneously driving the physical growth of the tissue, resulting in an enlarged, palpable goiter. The mechanism failing in the current patient presented a completely different physiological picture. The laboratory findings of elevated free hormones clearly demonstrated severe thyrotoxicosis, with high levels of circulating T4 and T3 driving the weight loss and tachycardia. According to the inviolable rules of the negative feedback loop, this overwhelming surplus of hormone would profoundly suppress the anterior pituitary gland. Consequently, the patient's intrinsic production of thyroid-stimulating hormone would have dropped to near zero, undetectable levels. Without the constant, necessary presence of this stimulating hormone in the bloodstream, the native thyroid gland was entirely deprived of its trophic support. Lacking the signal to produce hormone, or even maintain its cellular architecture, the native glandular tissue underwent a process of profound involution. The follicular cells shrank, the extraction of iodine from the blood ceased, and the overall volume of the gland significantly decreased. This state of physiological atrophy provided a perfect, logical explanation for the physical examination findings. The remarkably soft, flat, and impalpable anterior neck was exactly what would be expected from a native gland thoroughly suppressed by a prolonged absence of pituitary stimulation. to definitively assess the functional status of the thyroid tissue and trace the source of the hormonal excess, the clinical investigation shifted to nuclear medicine. A radioactive iodine uptake scan was ordered. This diagnostic procedure relies directly on the physiological principle of the sodium iodide symporter. The patient is administered a small, harmless dose of a radioactive iodine isotope. Because the body cannot distinguish between stable dietary iodine and the radioactive tracer, any active thyroid tissue will readily take up the isotope from the bloodstream to use in hormone synthesis. A few hours after the tracer is ingested, a specialized gamma probe is positioned over the patient's neck. This probe detects the radiation emitted by the concentrated isotope, allowing clinicians to quantify what percentage of the administered dose has been absorbed. In a normal individual, the uptake is moderate, reflecting the steady, balanced production of daily hormone requirements. In a patient with classical Graves' disease, the scan would show a dramatic, diffuse uptake, with the heavily vascularized gland glowing brightly on the imaging screen as it rapidly pulls the tracer from the blood. When the gamma probe was positioned over the neck of this specific patient, the results were entirely incongruent with autoimmune hyperthyroidism. The sensor detected almost no localized radiation. The calculated uptake of the radioactive tracer was virtually zero, hovering at less than 1% of the administered dose. The imaging screen revealed only the faint, scattered background radiation typical of the surrounding soft tissues. The native thyroid gland was taking up no iodine. It was synthesizing no hormone. The organ was functionally dormant, resting silently in the neck, completely suppressed by the massive quantities of thyroid hormone circulating in the blood. This objective imaging finding confirmed the mechanism suggested by the physical examination. Yet, it deepened the investigative complexity. The patient was suffering from severe, system-wide hypermetabolism, driven by an excess of thyroid hormone. But their own thyroid gland was essentially turned off. The high levels of circulating hormone had to be originating from somewhere else, entering the general circulation independent of the normal neuroendocrine axis, and bypassing the body's meticulous feedback controls altogether. When the native gland is turned off, but the bloodstream remains flooded with active hormone, the differential diagnosis narrows to a few highly specific physiological pathways. The condition could represent thyroiditis, a process where an inflamed gland passively spills its stored hormone into the circulation while halting new synthesis. Alternatively, it could indicate an ectopic source, such as a rare ovarian teratoma known as struma ovariae, which contains functional thyroid tissue operating outside the normal neuroendocrine axis. Finally, the source could be exogenous, meaning the hormone is being introduced from the external environment. To distinguish systematically between these possibilities, physicians utilize a specialized biochemical assay to measure serum thyroglobulin. Thyroglobulin is a large glycoprotein produced exclusively by the follicular cells of the thyroid gland, serving as the structural scaffold upon which thyroid hormones are synthesized. If a patient is experiencing thyroiditis or harboring an ectopic thyroid tumor, serum thyroglobulin levels will typically be elevated. Conversely, if the excess hormone is entering the body from an outside source, the dormant native gland produces virtually no thyroglobulin, resulting in profoundly diminished blood levels. The laboratory analysis returned a serum thyroglobulin concentration that was nearly undetectable. This definitive biochemical result conclusively eliminated both thyroiditis and ectopic hormone production from the differential diagnosis. The patient was formally diagnosed with exogenous thyrotoxicosis. The overwhelming surplus of metabolic hormone was undeniably entering the biological system from an external origin. In modern clinical practice, this scenario most frequently unfolds when a patient is prescribed a synthetic thyroid replacement medication and accidentally takes a supertherapeutic dose over a prolonged period. It can also occur when individuals unknowingly consume unregulated dietary supplements containing concentrated animal glandular extracts. However, a meticulous review of the patient's pharmacological records confirmed the complete absence of any such prescriptions, and a deliberate inventory of their household revealed no supplements or alternative remedies. The source of the thyrotoxicosis remained deeply obscured until the clinical interview transitioned into a highly detailed dietary history. It was during this slow, systematic review of nutritional intake that a consistent pattern finally emerged. The patient frequently consumed a particular type of ground meat, sourced from a local facility that utilized a specific anatomical cut known within the agricultural industry as gullet trim. Gullet trim consists primarily of the striated muscle and connective tissue harvested from the ventral neck region of cattle. Historically, if the commercial butchering process was not subjected to strict anatomical regulation, the bovine thyroid gland could be inadvertently left attached to the surrounding tracheal tissue and subsequently processed through the industrial meat grinder. Bovine thyroid tissue is exceptionally rich in biologically active thyroid hormones. These hormones are remarkably stable molecules. They easily survive the physical shearing of the grinding process, endure prolonged periods of deep freezing, and maintain their functional integrity even when subjected to the high thermal stress of standard cooking methods. When a human consumes this contaminated ground meat, the bovine hormones are seamlessly absorbed through the gastrointestinal tract and pass directly into the bloodstream, where they act identically to endogenous human thyroid hormone. This condition is a rare but well-documented historical phenomenon within the medical literature, commonly referred to as hamburger thyrotoxicosis. The diagnostic puzzle was complete. The patient was not suffering from an autoimmune disease, but rather a purely dietary exposure to concentrated bovine neuroendocrine tissue. The clinical treatment for this environmental presentation of exogenous thyrotoxicosis was remarkably straightforward, relying entirely on the absolute removal of the offending dietary agent. The patient was instructed to permanently cease the consumption of the contaminated ground meat products. Because circulating thyroid hormones possess a relatively long physiological half-life, the massive excess required several weeks to naturally degrade and clear from the systemic circulation. During this extended transitional period, supportive pharmacological therapy was carefully maintained. Beta-adrenergic blocking agents were continued in order to manage the elevated heart rate, reduce the fine motor tremors, and provide continuous symptomatic relief, while the hepatic and renal systems steadily metabolized the remaining bovine hormone. Gradually, as the exogenous hormone concentrations declined toward normal baseline parameters, the patient's native hypothalamic pituitary thyroid axis began to recover from its prolonged state of chemical suppression. The pituitary gland sensed the falling hormone levels and resumed its steady production of thyroid-stimulating hormone. This prompted the dormant native thyroid gland to gently awaken and eventually resume its normal, regulated synthesis of endogenous thyroxine. The resting tachycardia entirely resolved. The severe hypermetabolic state stabilized, and the previously lost adipose tissue and skeletal muscle were steadily regained. This progression from an assumed autoimmune disorder to an environmental exposure illustrates the profound necessity of revisiting initial diagnostic assumptions when objective data fails to align with the expected clinical pattern. It demonstrates how a definitive diagnosis often relies less on a single sudden realization than on the methodical, sequential elimination of physiological possibilities through precise biochemical testing. Ultimately, the resolution of this complex presentation underscores the enduring value of a thorough patient history, gently reminding us that the answers to seemingly intractable medical mysteries are frequently hidden within the ordinary routines of daily life. The ascending agony. The patient presented to the medical admission unit in the late afternoon, following a gradual but relentless decline over the preceding 4 days. The symptoms had begun quietly, initially manifesting as a faint, persistent tingling in the tips of the toes. Over the course of a weekend, this mild paresthesia deepened into a profound, burning ache that radiated through the feet and into the calves. By the second day, walking had become laborious. The patient initially attributed this difficulty to the discomfort of bearing weight, but it soon became evident that the legs simply lacked their usual power. On the day of admission, the weakness had ascended to the mid-thighs. Standing unassisted was no longer possible. The initial assessment was conducted with deliberate care. The patient was settled into a quiet examination room, and the attending physician began a thorough neurological evaluation. The patient described the pain as a heavy, continuous thrumming within the muscles, layered with a sharp, stinging sensation whenever the skin of the lower legs brushed against the bed linens. During the motor examination, muscle tone in the lower extremities was found to be notably reduced, presenting as a flaccid weakness. Strength in the ankles and toes was significantly diminished, graded at a 2 out of 5 on the Medical Research Council scale, meaning movement was possible only with gravity eliminated. The proximal muscles of the thighs retained a fraction more strength, mapping a clear gradient of impairment. The physician then evaluated the deep tendon reflexes using a standard reflex hammer. The patellar reflexes at the knees and the Achilles reflexes at the ankles were entirely absent. This finding, known as ariflexia, is a critical clinical marker. Sensory testing with a soft cotton wisp and a sterile pin revealed an altered perception of touch and temperature, conforming to a stocking glove distribution that extended halfway up the calves. Proprioception and vibration sense, tested with a low-frequency tuning fork, were mildly reduced at the joints of the great toes. Cranial nerve function remained entirely normal, and the upper extremities showed only a marginal sluggishness in the triceps reflexes, suggesting a condition that was steadily advancing upwards from the lower limbs. Given this meticulously documented clinical picture, the initial diagnosis was acute inflammatory demyelinating polyneuropathy, the most common variant of Guillain-Barré syndrome. This was a highly logical and evidence-based conclusion. Guillain-Barré syndrome classically presents as an acute, symmetrical, ascending flaccid paralysis, accompanied by absent reflexes and variable sensory changes. The patient also noted a brief episode of mild nausea and stomach discomfort roughly 10 days prior to the onset of the numbness. This timeline perfectly aligned with the standard pathophysiology of Guillain-Barré, which is frequently preceded by a mild gastrointestinal or respiratory infection. In such cases, the immune system produces antibodies to clear the initial pathogen. But due to molecular mimicry, these antibodies mistakenly bind to the myelin sheaths or nerve axons of the peripheral nervous system. This inflammatory attack disrupts electrical signal conduction, resulting in the exact pattern of ascending weakness and areflexia observed in the examination room. The medical team proceeded with an admission plan for presumptive Guillain-Barré syndrome, arranging for a lumbar puncture to assess cerebrospinal fluid protein levels, and preparing to initiate standard supportive therapies. The clinical evidence was overwhelmingly cohesive, drawing a clear line from the antecedent illness to the migrating paralysis. Yet, nestled within the admission notes was an observation regarding the sensory examination. While sensory changes are common in Guillain-Barré syndrome, this patient exhibited an exquisite, agonizing tenderness specifically isolated to the soles of the feet. The lightest contact of a cotton swab against the plantar surface provoked a disproportionate surge of neuropathic pain, a level of localized hyperesthesia that was slightly unusual for a standard demyelinating condition. The presence of this exquisite plantar hyperesthesia invited a closer examination of the underlying cellular mechanisms governing peripheral sensory nerves, extending far beyond the outer myelin sheath and into the very core of the axon itself. To fully understand the profound dysfunction occurring within these nerve pathways, it is necessary to first examine the normal physiology of peripheral nerve conduction and the immense energetic demands required to maintain it on a microscopic level. The peripheral sensory nervous system relies on some of the longest individual cells in the human body. A sensory neuron responsible for transmitting tactile information from the sole of the foot has its primary cell body situated within a dorsal root ganglion, located just outside the spinal cord. From this single microscopic cell body, a solitary nerve fiber, or axon, extends all the way down the leg, traveling through the deep tissues of the calf and branching into the distal extremities, often spanning well over a meter in length. This extraordinary physical distance creates a unique metabolic vulnerability. The axon is entirely dependent on the distant cell body for the synthesis of essential proteins, enzymes, and structural components. To transmit a sensory signal from the foot back to the central nervous system, the nerve relies on the propagation of an action potential. This electrical signal is only made possible by maintaining a precise difference in electrical charge and ion concentration across the cellular membrane, a state known as the resting membrane potential. In a healthy neuron, the interior of the cell is kept negatively charged at roughly negative 70 millivolts relative to the extracellular environment. This vital gradient is not a passive phenomenon. It is continuously and actively maintained by one of the most ubiquitous and important protein complexes in human physiology, the sodium-potassium pump. This transmembrane enzyme complex sits permanently embedded in the lipid bilayer of the cell wall. Its operation is a continuous masterpiece of molecular machinery. During every single cycle, the internal portion of the pump binds 3 sodium ions from the intracellular space. A molecule of adenosine triphosphate, or ATP, the primary energy currency of the cell, then binds to the pump and undergoes hydrolysis. This reaction transfers a phosphate group to the protein structure. The addition of this phosphate induces a significant structural conformation change in the pump, opening its channel to the extracellular space and releasing the 3 sodium ions outside the cell. Simultaneously, the new shape of the protein exposes highly specific binding sites for potassium ions on its extracellular face. 2 extracellular potassium ions bind to these sites, a reaction that prompts the release of the attached phosphate group. Without the phosphate, the pump reverts to its original structural conformation, pulling the 2 potassium ions inside and depositing them into the intracellular fluid. This continuous, rhythmic exchange, 3 sodium ions pumped out and 2 potassium ions pulled in, maintains a high concentration of potassium inside the cell and a high concentration of sodium outside. The selectivity of these binding sites is exquisitely tuned to the specific physical properties of these ions. The pump distinguishes between ions based on their ionic radii and the precise spheres of water molecules that hydrate them in solution. Potassium, being a monovalent cation with a highly specific atomic size, fits perfectly into the binding pockets of the pump, allowing the cycle to continue millions of times per second across the surface of the nerve cell. The metabolic cost of maintaining this electrochemical gradient is immense. In nerve tissue, the activity of the sodium-potassium pump alone accounts for a vast proportion of the cell's total energy expenditure. This relentless demand for ATP requires a highly efficient and continuous system of cellular respiration, which takes place entirely within the mitochondria. Mitochondria serve as the localized powerhouses of the neuron, utilizing oxygen and glucose to produce ATP through the citric acid cycle and the electron transport chain. Within the folded inner membranes of the mitochondria, a series of protein complexes pass electrons down an energy gradient to ultimately generate ATP. This complex system relies on several specific enzymes, many of which depend entirely on the structural integrity of sulfhydryl groups. A sulfhydryl group, or thiol, consists of a sulfur atom bonded directly to a hydrogen atom. These structural groups are essential for the catalytic activity of enzymes such as pyruvate dehydrogenase, which acts as the critical biochemical bridge linking glycolysis to the citric acid cycle. Without functioning sulfhydryl groups, these enzymes cannot process metabolic substrates, and cellular respiration completely ceases. Because the axon extending all the way to the foot is so remarkably long, local energy demands cannot be met by simply relying on the cell body to diffuse ATP over a distance of a meter. Instead, the mitochondria themselves must be transported from the cell body down the entire length of the axon to the distal nerve terminals. This is achieved through a sophisticated logistical system known as axonal transport. Microtubules form long, parallel tracks running the length of the nerve fiber. Motor proteins, specifically chymsin for outward transport and dynein for return transport, operate as molecular motors. They physically step along the microtubule tracks in a hand-over-hand motion, carrying mitochondria and vesicles filled with neurotransmitters toward the distant synapse. Each individual step taken by a chymsin molecule requires the hydrolysis of one molecule of ATP. Therefore, this entire supply chain is completely dependent on an uninterrupted local supply of energy. In the context of this patient's progressing neuropathy, this elegant system of electrochemical gradients, mitochondrial energy production, and axonal transport was facing a quiet, catastrophic failure. This failure was driven by a mechanism fundamentally different from the autoimmune demyelination initially suspected. The patient had been exposed to a heavy metal that acts as a near-perfect molecular imposter. This particular toxic element exists in the body as a monovalent cation with a positive 1 charge, identical to the charge of a potassium ion. More critically, its ionic radius is remarkably similar to that of potassium. When this heavy metal enters the extracellular fluid and encounters the cell membranes of peripheral nerves, the biological machinery is completely unable to distinguish it from the essential nutrient. The sodium-potassium pump, functioning precisely as designed, inadvertently binds this toxic element in place of potassium. In fact, the biological affinity of the pump for this heavy metal is actually greater than its affinity for potassium itself, causing the pump to actively and preferentially draw the toxin from the blood and concentrate it deeply within the intracellular space of the neuron. Once inside the cell, the dual nature of the poison is fully realized. It has entered disguised as an essential electrolyte, but upon gaining access to the cytoplasm, it begins to act according to its heavy metal properties. Like many heavy metals, it possesses a profound and destructive chemical affinity for sulfur. It aggressively targets and binds to the sulfhydryl groups on the critical mitochondrial enzymes. When the toxin binds to the sulfhydryl groups of pyruvate dehydrogenase and other vital enzymes within the citric acid cycle, it immediately alters their three-dimensional structure, rendering them completely, permanently inactive. The effect on cellular respiration is devastating. Oxidative phosphorylation grinds to a halt, and the neuron's ability to synthesize ATP plummets. Without sufficient ATP, the fundamental operations of the nerve cell begin to collapse. The sodium-potassium pumps stall. The continuous transport of materials down the microtubules fails, meaning fresh mitochondria can no longer be delivered to the distal nerve endings. This intracellular energy crisis explains the specific, localized presentation of the nerve damage. Because the sensory neurons supplying the soles of the feet have the longest axons in the body, they carry the greatest metabolic burden and rely on the longest supply lines. They are uniquely susceptible to disruptions in axonal transport and energy production. When ATP levels drop, the distal ends of these long axons are the very first to suffer. The nerve terminals in the feet begin to degenerate in a process known as a dying back neuropathy or a length-dependent distal axonopathy. As the structural integrity of the distal axon breaks down, the local resting membrane potential can no longer be maintained. The nerve membranes become highly unstable, leading to spontaneous, chaotic depolarizations. The brain interprets these aberrant, unregulated electrical signals not as normal physical contact, but as profound, continuous, and extreme pain. This distal axonopathy is the precise biological source of the severe plantar hyperesthesia observed during the physical examination. The lightest touch of a cotton swab triggers an avalanche of unstable electrical activity in the energy-starved, degrading nerve terminals, resulting in agonizing discomfort. The ascending weakness and the loss of reflexes were not the result of an immune system attacking the myelin sheath, but rather the progressive, energy-starved death of the axon itself, marching steadily upward from the furthest outposts of the peripheral nervous system as the cellular batteries ran dry. The exact reason these cellular batteries were failing became apparent only when the clinical presentation diverged from the expected course of an immune-mediated polyneuropathy. For the first 2 weeks of hospitalization, the profound lower limb pain and the ascending weakness had been managed under the working diagnosis of an acute motor and sensory axonal neuropathy, a severe variant of Guillain-Barré syndrome. The standard therapies for immune demyelination, such as intravenous immunoglobulin, had been administered without yielding any clinical improvement. The neuropathy continued its steady, agonizing ascent, and the medical team remained anchored to their initial immunological hypothesis. A distinct physical sign then emerged, one that fundamentally dismantled the working diagnosis. In the span of just a few days, roughly 3 weeks after the onset of the initial neurological symptoms, the patient began to shed hair at a remarkable volume. This was not a subtle thinning. It was a rapid, near-total loss of scalp hair, alongside the loss of the lateral thirds of the eyebrows. The hospital linens were continually covered in shed follicles, and within a week, the patient had developed complete alopecia. Alopecia is not a known manifestation of Guillain-Barré syndrome, nor of any common post-infectious autoimmune neuropathy. This dermatological development forced a complete reassessment of the clinical picture. When a painful, ascending sensory motor neuropathy is paired with severe hair loss, the diagnostic algorithm shifts entirely away from autoimmune conditions and focuses squarely on toxicology. This specific combination of symptoms is a classic hallmark of heavy metal toxicity, and it is most definitively associated with thallium poisoning. Thallium is a highly toxic heavy metal that is virtually tasteless, odorless, and colorless. Because its ionic radius is nearly identical to that of potassium, the human body readily absorbs thallium, mistaking it for this essential intracellular electrolyte. Once inside the tissues, thallium disrupts multiple critical enzyme systems, particularly those relying on potassium, thereby halting mitochondrial oxidative phosphorylation. This profound energy failure is what drives the excruciating dying back neuropathy. The alopecia occurs because thallium disrupts the rapid cellular division in the hair follicle matrix. The follicles are prematurely pushed out of their growth phase, a process known as anagen effluvium, leading to uniform shedding a few weeks after the initial exposure. A 24-hour urine collection was ordered for heavy metal screening, along with comprehensive blood serum panels. The toxicological analysis returned showing thallium levels significantly exceeding the normal reference range, providing unequivocal confirmation of severe thallium poisoning. With the true etiology identified, the focus of medical care shifted to targeted decontamination and the promotion of elemental excretion. The established antidote for thallium toxicity is a compound known as Prussian blue. Administered orally, Prussian blue is a complex lattice of iron and cyanide that is not absorbed by the gastrointestinal tract. Instead, it travels through the intestines, acting as a highly specific chemical trap. Thallium undergoes continuous enterohepatic circulation, meaning the body excretes it into the bile, only to reabsorb it further down in the digestive tract. As the thallium is secreted into the intestines, the potassium ions within the Prussian blue lattice are exchanged for the thallium ions. The heavy metal becomes irreversibly bound to the drug and is safely eliminated from the body through the feces. The patient was started on a continuous regimen of oral Prussian blue, alongside aggressive supportive care and intensive pain management. Over the following weeks, the systemic thallium levels steadily declined. The hyperesthesia in the feet and lower legs gradually began to subside as the toxic burden was lifted from the peripheral nervous system. The progression of the ascending weakness halted, and the spontaneous depolarization of the sensory nerves slowly quieted. Recovery from severe heavy metal axonopathy is a prolonged process dictated by the extraordinarily slow rate of peripheral nerve regeneration. It required several months of dedicated inpatient physical rehabilitation for the patient to regain the ability to walk independently. The scalp hair entirely regrew over the next 6 months as the follicles resumed their normal mitotic cycles, while the most severe aspects of the nerve pain resolved completely. The patient was left with a mild, residual distal numbness in the toes, a permanent artifact of the initial axonal destruction. This sequence of events offers a clear illustration of how clinical diagnosis actually functions in complex presentations. It demonstrates that an initial clinical framework, no matter how logically it incorporates the early neurological deficits, must remain subject to revision when anomalous data emerges. The unexpected appearance of alopecia acted as an essential biological correction, breaking the momentum of a deeply anchored misdiagnosis. It is a reminder that the physical examination will ultimately reveal the true pathology, provided the clinician is willing to abandon a failing hypothesis and follow the physiological evidence wherever it leads. We'll pick up somewhere else tomorrow night. Rest now